Hi, I'm Dr. Stephen Pipe. I'm a professor of pediatrics and pathology at the University of Michigan. And I've spent my entire career taking care of patients with hemophilia. And in recent years, it's been my pleasure to be engaged in a number of clinical trials which are looking to the future for care for these patients, and that's gene therapy. And so what I'd be happy to talk to you about today is really the exciting results from etranacogene dezaparvovec, which is used to be called AMT-061. This is an investigational gene therapy, and it's for patients with hemophilia B. This is the less common form of hemophilia. The more common form of hemophilia is hemophilia A, which is factor VIII deficiency. So this is hemophilia B, which is factor IX deficiency. But there are, thousands and thousands of patients all over the world who are affected by this condition. What EtranaDez is aiming to do is to relieve patients from the burden of the therapy that we've been applying in this disease category for several decades, and that is prophylactic replacement therapy. We've been able to take initially plasma-derived factor IX products and then recombinant factor IX products, and then we had development of these bioengineered longer-acting factor IX products, all sort of incremental improvements in the ability to replace the missing clotting factor in their blood. But the burden of this therapy is still pretty high. All these therapies have to be given intravenously. Even with the longer acting factor IXs, patients are really, chained down to a prophylactic regimen that looks like an IV infusion about once a week, which they do at home. But this is lifelong. And the goal of that prophylactic therapy is, of course, to prevent bleeding events. The hallmark of bleeding in hemophilia particularly is bleeding into joints, and repeated bleeding into those joints leads to severe, initially synovitis and then hemophilic arthropathy, which can be devastating for a patient in their older years. So, we've done very well with prophylactic therapy for a number of years, despite both the cost burden and the burden of the administration for the patients. But what gene therapy hopes to achieve here is, instead of replacing the protein, we're going to replace the gene, the defective gene that's in their liver that's making it so that they can't make their own factor IX into their plasma. So the trick with gene therapy then is we've had these recombinant genes for factor IX. That's how we've made recombinant factor IX for a long time. But how do we get the gene into the liver? And so the breakthrough really came about 20 years ago, when we identified these non-pathogenic viruses that could be turned into vectors called adeno-associated virus vectors. And these don't cause any disease pathology in humans, but they target to the liver. And we can take out the viral genes and design these vectors so they only contain a payload that contains the factor IX product itself. The AAV vectors can target to the liver. The payload inside the vector is the factor IX gene, and it gets taken up by the liver cells. The gene, once it gets delivered to the nucleus, codes for the factor IX protein, and the natural machinery of the cell makes the factor IX and secretes it into the plasma. And what happens is the patients have a gradual rise in their factor IX levels until it reaches sort of a steady state from production and natural clearance. And this is a measurable steady state level that we can measure in the patient's plasma. And we know some targets for what kind of plasma levels would likely stop all bleeding. Now, particularly, we want to stop joint bleeding, but we have some levels in mind where we think we could achieve and probably prevent even significant traumatic bleeding. And so that's what we're aiming for with this therapy. Over the last 20 years, it's been a series of studies trying to design these vectors better, trying to design the payloads better, and then overcome some of the immune challenges that the human immune system has posed, that has maybe made it a little bit more challenging to get these steady state levels. Well, I think EtranaDez has now shown that we've been able to overcome almost all of those hurdles. EtranaDez uses a particular subtype of the AAV vector called AV5. This is chosen because the minority of the population are going to have ever seen an AAV virus that looks like AV5, so they won't likely have prior immunity against that vector. But as it turns out, in the early studies for EtranaDez, what we learned actually is that even patients who did have antibodies which could react against the AAV vector, it didn't seem to impact on the efficacy of the gene therapy treatment. We saw this in the initial phase 1/2 trial, and we were so intrigued by this data. We did a very small study with 3 patients, which is called the phase 2B study for EtranaDez, and we were one of the study sites at our center. And we observed in these 3 gentlemen, all 3 of them had pretty high titers against the AAV5 vector. We enrolled them in the trial, and they all achieved really outstanding, durable results and expression from factor IX. So that emboldened us in the Hope B trial, which is the phase 3 trial, which we're really going to focus on today, that we would not screen out patients just because they had pre-existing what we call neutralizing antibodies. This is a differentiator from essentially every other gene therapy that's out there right now for hemophilia, both for hemophilia A and hemophilia B. Populations of patients who are otherwise eligible have screened out based on neutralizing antibodies. We did measure the neutralizing antibody levels in the 54 participants that were enrolled in this trial, and it turns out that 42% of them actually had neutralizing antibodies, but we went ahead and we dosed all of them. And as it turned out, there was only a single patient who had what I would call a sky-high level of neutralizing antibody, probably at the 98th percentile of the population expectation of who would have these kinds of levels. He did not respond to the therapy, unfortunately. So there's probably a limit, but it seems like it's quite high. So all the other participants had neutralizing antibodies. Not only did they get good expression, we didn't see any correlation between their antibody titers and the level of factor IX that they achieved. And there was no evidence of any adverse events that tended to track with the patients who had the neutralizing antibodies. So I think this is a really impressive insight that we gained from this trial, and it's going to impact greatly the patients who will be able to be eligible to receive this kind of therapy. So the way we designed the phase 3 trial is, of course, the goal for this gene therapy is to have a single treatment event that gets stable factor IX levels that are in a range that would hopefully prevent all bleeding, but certainly joint bleeding. And then we want to assess the durability. And the way we measure the efficacy is we're going to look at something called the annualized bleed rate. So this is a calculation that's based on observed bleeding events that we annualize. So if a patient has, 2 bleeds in 6 months, that would be an annualized bleed rate of 4. Okay, that's how the calculation is given. So we're bringing this therapy to a standard of care of prophylactic factor IX therapeutics that we have available, as I said at the beginning. So we needed to be able to compare before and after gene therapy. So all the patients participated in at least a 6-month lead-in phase where they were maintained and observed on their standard of care factor IX prophylaxis, and we collected the amount of factor they used, how many infusions they gave themselves over that period, and then what their annualized bleed rate was. Then they all got this single infusion of EtranaDez, goes in over 1 to 3 hours. It's an outpatient procedure, pretty inconsequential for the majority of patients. And then we observed them. They had a little bit of overlap of their factor prophylaxis around the time of the administration, and then we just waited for their factor levels to come up. And the top line number is after following these patients now for 18 months, the factor expression was really quite remarkable. So the just going to give you the exact number here. So the mean factor IX activity was 39% that was measured at month 6. That's when most patients had sort of stabilized after the treatment. And then we followed them now out for 18 months. And at 18 months, the factor IX expression was still almost 38%. So really very stable compared between those two endpoints. Now, to give some benchmarking for that, patients with severe hemophilia B have less than 1% factor IX activity. We enrolled patients in this trial up to a limit of 2%. So they were severe and what we would call moderate severe. What sort of levels are needed to prevent joint bleeding? Most people would say that if you can maintain a levels that are above 10 to 15%, you're unlikely to be at risk for joint bleeding. And if you get up to levels that are what we consider the non-hemophilic range, is basically above 40%, then we expect you to have the normal, if you like, clotting system of a person who does not have hemophilia. So the mean levels here are really just abutting on that non-hemophilic range. And so, as you can imagine, we should be seeing very good protection from bleeding from this kind of outcome. So the primary outcome for this study was to look at the 52-week annualized bleed rate from the point where they achieved stable expression after gene therapy, which was at the 6-month point, and then 52 weeks later, all the way to the 18-month point. And that's where the results really are really outstanding. Now, remember, we're comparing against standard of care as of 2021, 2022, factor IX prophylaxis. So the annualized bleed rate for the population of patients who participated while they were on factor IX prophylaxis was an annualized bleed rate of just over 4 bleeds per year. And if we compare that to after gene therapy for that 6-month through 18-month time period, the annualized bleed rate was actually better controlled post-gene therapy. It was 1.5. Now, we went one extra step because we know that patients in this age group, this was age 18 and up into late adulthood, we know that after you've had multiple bleeds over many, many years and decades in your joint, sometimes it can be difficult to distinguish real bleeding into the joint from like arthritic pain. And so we had the option for the individual investigators to adjudicate the bleeding events that the patients were reporting. So if they did report a bleed, there would be a conversation or perhaps even a physical exam, or if needed, the investigators could even do some imaging studies to verify if there was actual bleeding. And if we look at the investigator adjudicated factor IX treated bleeds, actually the number goes down to 0.83 annualized bleed rate post gene therapy, and compared to the lead-in phase, which was 3.65. So this is actually the first treatment intervention that shows superiority to standard of care prophylaxis. I think this is a monumental achievement. And since the patients essentially didn't need prophylaxis, except for that one individual who didn't respond at all to the therapy, everyone else was able to come off their prophylactic therapy and just rely on the expression from the gene therapy. So 52 of the 53, or 98% of them, have remained off of prophylaxis. And if we look at the amount of factor that group has used as a group, there's been a 97% reduction in the amount of factor IX that's been needed post-gene therapy compared to the lead-in phase. So I'm really excited about these results. The next important question that usually is asked about this therapy, okay, well, what risks do you have to embrace to get this kind of an excellent outcome, this kind of efficacy? Well, I mentioned first risk is that you might not be eligible, but we've overcome that because we choose patients who have uh, healthy livers. Now, granted, this population of patients had been scarred by transfusion transmitted infections back in the early 80s, hepatitis C, HIV. So we had to make sure that their livers were healthy coming into this trial, and we had to ensure that their HIV was controlled if they had HIV, and they had to have gone through hepatitis C eradication therapy. But if they fulfilled those requirements, the nice thing was we didn't screen them out based on neutralizing antibodies, so that allowed 43% more patients to participate in the trial. And then what we watch for after dosing, after you get through sort of mild infusion-related reactions associated with the delivery of the EtranaDez, what we actually watch for is evidence of what we think is an immune response to the vector getting into the liver cells. And the way that this has been manifest in previous trials is a modest bump in the liver enzymes that you can measure with standard chemistries. And particularly, we're looking at a liver-related enzyme called the ALT. When we saw that, we had a preordained protocol. So we would initiate patients on a short course of oral corticosteroids, so basically prednisolone. And the idea there was to suppress the immune response, get the liver enzymes back to the normal range, and protect those liver cells so that they wouldn't lose expression of the transgene. And that actually turned out to be fairly successful. It was only a small number of patients who actually triggered the steroid protocol. All of the patients came off the steroids before the 6-month sort of window that we were going to evaluate for the primary endpoint, and none of them have had any resurgence of their liver enzyme elevations over the rest of the follow-up period. So it's something that we would tell the patients going into this therapy, that this is something that would be part of their follow-up, that we'd have to monitor them for these liver enzyme elevations, and then we would most likely, even in a commercial application of this, we would have a protocol for giving them a short course of corticosteroids. After that, boy, these patients are awfully happy. It's been such a joy. I think you wanted me to sort of talk about a day in the life of a gene therapy researcher. Well, most of the work is in preparation of the patient, getting them ready, getting through all the protocols at my hospital to make sure that I've got everything prepared and everybody knows how to handle this product and get it administered safely. There's a reasonably intensive follow-up period. We're checking labs about every twice a week to weekly, but then after they get past that about 6-month time point, the intensity of the monitoring goes way down. And now I've been following some of the guys on the Hope B now. They're into close to 2 years post gene therapy. If I didn't make them come back for the study visits, I'm not sure they would really venture to the hospital because they're feeling great. They're not bleeding. Most of them, interestingly, don't even ask me about their factor levels. I mean, obviously, I've told them over time, but they're recognizing that the actual factor level doesn't really matter that much to them anymore because they're not bleeding, they're not doing prophylactic infusions, and they're just living their life. What I hear often is the spontaneity that's come back to their life, not having to think about a particular activity, whether it's risky for bleeding, whether they need to give an infusion before they go out and, do an activity on a weekend or play with their grandkids or pick up their kids at home or anything along those lines. So that's been a real advantage. And many of them have talked about how it's actually even influenced some of their life decisions. What kind of work they want to be involved in. Maybe they had been on a path of relatively sedentary work before, based on the status of their bleeding, but now some of them have embraced to be a quite a bit more active lifestyle. Some of them have been willing to pick up and move to different parts of the country because they kind of feel emboldened that their hemophilia isn't tying them down to any particular local care requirements. So that's been really exciting to sort of see that unfold for patients who've gone through this treatment. For me, I'm still very keen to monitor the long-term outcomes from this treatment. I think this is an important aspect, and we definitely have this conversation with everyone who participates in gene therapy. So what happens to the gene when it gets into the nucleus? So it turns out that the way AAV delivers these transgenes, it doesn't actually what we call insert the genetic material into your own chromosomes. Primarily, the transgene that gets delivered, this segment of DNA, circularizes inside the nucleus, and it stays sort of outside of your normal chromosomes. That's an advantage because we really don't need it to be integrated into your chromosomes. It expresses fine off these circular, what we call episomes. And because adult liver cells are reasonably long-lived, we don't have to worry about the expression petering out, anytime soon. It does mean, though, that we probably can't use this platform of therapy for children because it doesn't get inserted into the chromosomes. So in a developing liver in a child, as those cells divide into daughter cells, the daughter cells will not carry the transgene to the new cells. So almost certainly the expression would be diluted out over time. So I think this protocol could probably start to be applied to adolescent age patients. We think good maturity of the liver after about age 12 to 14, but younger, preschooler and up, I think this platform of therapy is not going to be effective over the long run. Now, when I say it primarily doesn't integrate into the chromosomes, that doesn't mean exclusively. And we've had opportunity from taking biopsies of patients who've gone through gene therapy to have an assessment of how frequently do insertional events occur. They're quite rare, to the tune of about 0.03% of the cells may have some evidence of an integrating event where a portion of the transgene has inserted into the DNA of the patient's chromosomes. Where does it insert? It's not entirely random, but it doesn't, it tends to insert into active parts of your genome. So it's not going to insert into an area that's supposed to be silent from your genes. And in turn, it also doesn't seem to have any sort of predilection to associate with cancer-causing type genes. We all have genes which are tightly controlled, which we don't want to be overactive because that can drive proliferative events that might have tumorigenic potential. So we've looked for those over the years. Like I said, several decades of investigation with the AAV work. We've never seen tumorigenesis in any animal model or in any of the clinical trials to date. But we're going to continue to monitor these patients. We want to make sure that we're telling this community over the long haul, over many decades, that this really is a safe procedure. So we're going to be inviting patients who participate in these trials to finish out the follow-up on the trial, which will probably be about 5 years. But then we're going to enroll them or invite them to participate in these national registries where we're going to continue to follow them for multiple decades afterwards. And we're going to pool our information across the world. There's actually there's a foundation called the World Federation of Hemophilia, WFH, and they have generated a global registry that's going to be rolling out in the coming year, and all nationalities who want to participate will be able to send their data to this global database and pool the resources. And we think that is going to add great power to describe the efficacy, to describe acute side effects and safety events as they may occur, but also to provide hopefully reassurance to the community over the long term that we've not introduced any serious adverse event that patients might be at risk for over multiple decades afterwards. So I think now, even though I just jumped into gene therapy here in the last 5 years doing clinical trials, almost certainly patients who've undergone gene therapy are going to be part of my practice for hopefully many years to come as well.